Okay, so in this module, we're going to talk about a mixture of things: electrolytes, acid-base balance, diuretics, different types of diuretics, and different types of IV solutions that can be given to patients. So here is a image of a nephron. So at the beginning, you have the glomerulus, where that tuft of blood vessels are, uh, the glomerular blood vessels. And then you have the proximal convoluted tubule, that first part. Then you have the descending loop of Henle, the ascending loop of Henle, the distal convoluted tubule, followed by the collecting ducts. And the collecting ducts, if you were to take all of them, they're the ones that start to combine together in the pyramid of the kidney to then drain into the minor calyces and then the major calyces and finally into the renal pelvis. Okay, so each kidney has 1 million nephrons approximately. So the collecting ducts is basically the last part where drugs typically act. And then after that, it's combining with other collecting ducts, and then finally draining the urine to the bladder. So a good way to think of diuretics in general is the closer they act to the glomerulus, typically the stronger they are. Okay, the more impact they have. So a diuretic is just a drug that can make more urine, that can drain you of more fluid in the body. Okay, so if you look at the first part, and we'll come back to these later, and these are rarely used. And why are they rarely used? Because they're so impactful. They produce a lot of urine very quickly. They have a lot of electrolyte imbalances, so we don't use them very often except in certain emergencies. So the carbonic anhydrase inhibitors, okay, the drug we're going to talk about in that group is acetazolamide. Don't worry, we'll get back to it. Osmotic diuretic, the main one in that group will be mannitol. And again, we'll talk about both of these and how such a strong, they're a very powerful diuretic, each one of them. And then we have the loop of Henle, and so there's a group of drugs called loop diuretics, right? And the prototype for that would be furosemide, which is Lasix. There's another one in that group called butanamide. Just remember the ending. They're very similar. Furosemide, butanamide. And they have a significant diuretic effect because they're still working quite proximally to closer, quite close to the glomerulus. So they have a significant diuretic effect. Okay, and then as we go along, there's the thiazide diuretics that act at the distal convoluted tubule. They won't be as powerful. They won't have such a diuretic effect. And then lastly, the collecting ducts. There's a group of drugs called potassium-sparing diuretics. What that means is, yes, they're still diuretics. They drain you of fluid, but they don't drain you of potassium like other diuretics do. Okay, so for example, the loop diuretics, well, they stop absorption of potassium, of sodium, of chloride, and water. So you're basically draining all of your electrolytes. Okay, and then of course water typically follows sodium, so Water goes down the tubule as well and out the collecting duct. The distal convoluted tubule where the thiazide diuretics work, well, they drain you of potassium and chloride and sodium. So, but just not to the same extent as the loop diuretics. Okay. So the potassium diuretics, and we'll talk about a couple of these, they drain you of some fluid. They drain you of sodium, but they don't drain you of potassium. And we'll talk about how that works a bit later when we're into those drugs. Okay. The ones at the beginning, they drain you of incredible amounts of fluid and electrolytes, the carbonic anhydrase inhibitors and the osmotic diuretics. Okay, so just keep an image of this in your mind and keep an image of where the groups of drugs work, and then they'll make a bit more sense as we go through them. Okay. Okay, so this slide, electrolyte review. So the first one, so these are our renal function tests, okay? Kidney function tests. Blood urea nitrogen, or BUN, and creatinine. Okay, and there's the normal values for each one, 10 to 20 for BUN, and creatinine 0.6 to 1.2. And where did these come from? So BUN, so these are just basic measurements of, we associate these with basic measurements of kidney function, okay? So if the kidneys, for example, are weak and not filtering properly, you can expect BUN and creatinine to climb in the bloodstream because they're not being filtered by the kidneys. But there's other conditions that can cause an elevation of these factors in the blood. So for example, blood urea nitrogen, well, nitrogen comes from breakdown of protein and amino acids. So if you consumed incredible amounts of protein, say you went onto some crazy high protein diet, well, we might expect you to have an elevated BUN in your blood if we checked it, even though your kidneys are still fine. Say you had severe dehydration or burns. Burns, you become dehydrated. So we're going to lump those together. What happens there? Well, if you're severely dehydrated, you're not filtering, you're not supplying blood to your kidneys to be filtered. So your BUN is going to climb very quickly. BUN tends to climb very quickly if something happens in the body, something sudden happens, such as, say, dehydration or a burn. The BUN is what goes up first because the body is always breaking down proteins to amino acids and then to nitrogen to be excreted by the kidney. So it shoots up fast in conditions such as dehydration. Well, what happens in burns? You get dehydrated, okay, because you're losing tremendous amounts of fluids through the burn. You get hypotensive because of all the fluid loss, and all the toxic breakdown of these cells is clogging up the kidney, the nephrons, a condition called rhabdomyolysis. So in rhabdo, you have in burns, you have kidney injury from all these toxins and breakdown products from cells blocking the nephrons. And you also have dehydration. So both of those will cause your BUN to go up. Impaired kidney function, we spoke about. If you have impaired filtration to your kidneys, your BUN is going to go up. And anything where you have increased protein breakdown. So, for example, if you're starving, what's your body going to do? It's going to consume all its sugars, the stored glycogen in the liver, and then it's going to start to break down fats, and then it's going to start to break down proteins in the body. So if you have increased protein breakdown, you will have an elevated BUN as well. So think of BUN and creatinine as kidney markers, but other conditions can cause them to be elevated. So let me give you one more example for BUN. A gastrointestinal bleed. Well, what happens when you have a stomach bleed? You become hypotensive because you're losing blood in your stomach. All the blood that's going down your gastrointestinal tract is being broken down and reabsorbed because the body wants to keep all the nutrients, the red blood cells. Well, red blood cells have proteins in them, and when all the blood gets reabsorbed, what does it do? The liver breaks down the protein and the amino acids, and the byproduct is nitrogen, and you get an elevated BUN for two reasons. For one, you're hypotensive and you're not filtering the kidneys, and secondly, all this blood that's being reabsorbed from the gastrointestinal tract and being broken down in the liver is producing more nitrogen. Okay, creatinine, same thing. It's released by muscle breakdown in the body. So if you're extremely muscular, or if you went for a long marathon jog or run, you could have an elevated creatinine just by the muscle breakdown from the activity you did. Okay. Impaired renal function, well, that's typically how we think of creatinine, that your kidneys just aren't working well. So it's a kidney marker test that we use. What about heart failure, shock, and dehydration? Okay, well, if you have heart failure, you're not pumping a lot of blood forward, so less blood is going to the kidneys. If you have shock, you're hypotensive, and if you have dehydration, you're hypotensive. So all of those just cause reduced blood flow to the kidneys. And if you have reduced blood flow to the kidneys, then you're certainly not filtering a lot of blood since they're not getting there. And the nitrogen that's produced from your liver, from the breakdown of amino acids, is still going on. So you get an increased BUN and you get an elevated creatinine. Okay, because the kidney has to receive blood flow to filter either one of these. Okay, so if you're in a big accident and you have severe muscle injury, you could have an elevated creatinine. If you have something that with a lot of exertion, you could have an elevated creatinine because you've used your muscles so much, some of them have broken down. Impaired renal function we've spoken about. Okay, so anyways, think of them as kidney tests, markers of the kidney function. Think of where they come from. Creatinine comes from muscle breakdown and is filtered by the kidney. So anything that causes muscle to be injured or overexerted can increase your creatinine. BUN, the nitrogen, comes from protein breakdown. And anything that causes you to either ingest a lot of protein or increased protein breakdown can elevate your BUN. Okay, so the plasma in your blood, so we're on to acid-base pH balance. So your serum or your plasma has to maintain a very, very tight pH in your bloodstream. Okay, 7.35 to 7.45. So that balance is constantly being monitored and adjusted in the bloodstream. And why do we need a pH between 7.35 and 7.45? Because all your enzyme processes, all your cellular metabolism is reliant on a very well-controlled pH in the bloodstream. Okay? And as you fall below 7.35, you become acidotic. As you go above 7.45, you become basic or alkalotic. Okay? So the body will do everything it can to maintain the system or the plasma in that narrow margin of 7.35 to 7.45. So let's look at the left slide, acidosis, by far the most common and most concerning of the two. Alkalosis is not that common. We don't see it very much, but we see acidosis all the time. And why do we see acidosis all the time? Because most of the processes in your body, the enzyme processes, the cellular metabolism, are constantly making acids and secreting them into the bloodstream, where your kidneys have to get rid of them, or they have to be buffered to maintain that pH of 7.35 to 7.45. Okay? So the body is constantly producing acids. So if something goes wrong with the body, it's typically you're going to become acidotic. Okay? And we can play with the pH a bit. We try not to, because we start altering other electrolytes in the body. But one option we have is if the pH drops below 7.35, we could give a patient sodium bicarbonate. And sodium bicarbonate combines with H+ to become H2O and CO2 that you can actually breathe off, right? So you could actually absorb or have some of the acid react with sodium bicarbonate, which will then raise the pH back into the normal level. Okay. What about the opposite, alkalosis? You're going to see that not many conditions produce alkalosis or a high pH. What could we do if we had a situation where the pH was too high? Well, we could add some kind of acid, such as ammonium chloride, to the bloodstream, and the acid will combine with the alkalosis to lower the pH back into the normal range. That is not commonly done. I know we're going to talk about ammonium chloride a bit. It's rarely done because there's not a lot of conditions that produce alkalosis. Okay, so if you're going to understand one of them better than the other, it really should be acidosis. Okay, and we'll get to that. Okay, if you have a piece of paper in front of you, I would just write a very simple equation. So the equation is H2O, which is water, plus CO2, which is carbon dioxide, and then put an arrow that goes in both directions. So H2O plus CO2 becomes H2CO3. And then continue with another arrow after the H2CO3, because that will become H+ and HCO3-. Okay. So the reason I asked you to write down this equation is on the left-hand side of the equation you have H2O and CO2. Okay, and this equation is constantly going back and forth in the body. On the other side, you have H+ plus HCO3. Well, that H+ is acid. Okay, So if you have conditions that are producing a lot of CO2, and those are typically respiratory conditions, because if you're not able to blow off your CO2, well, the equation is going to, so your CO2 is going to become elevated in respiratory conditions such as severe asthma or severe COPD or severe pneumonia. Your CO2 is going to become elevated because you can't breathe it off, you can't ventilate it off. And as that gets elevated, the equation is going to go over to H plus and HCO3 minus. So you're going to produce more H plus. You're going to become acidotic. And what's the cause of the acidosis in that case? If it was because of your CO2 going up, it is a respiratory acidosis. Something in the lungs caused your CO2 to be elevated, which then led to this equation to shift to the other side and cause an excessive acid, H plus, which then drops your pH, and you develop a respiratory acidosis. Okay. So let's look at the conditions in the top left-hand corner, and they should make sense now. So hypoventilation or shallow breathing. Well, if you're hypoventilating because you were given an overdose of morphine, or you took too many benzodiazepines, too many sedatives, well, you're not going to blow off your CO2. And because of that, the CO2 is going to rise in the bloodstream, and it's going to shift. It's going to combine with water and shift to H plus in the bloodstream. And that is acidosis. So your pH is going to drop, and you have a respiratory acidosis. All the other ones will make sense because the same thing's going to happen. So airway constriction, such as in severe asthma, will do the same thing. You'll get an elevated serum CO2. Damage to the respiratory center in the brain. Well, you're not going to breathe very well if you have damage to the brainstem. So you will have an elevation of CO2 in the bloodstream, and that will cause you to become acidotic, because you're not breathing off the CO2. Okay, let's look at the top right. Respiratory origin of alkalosis. Well, you can see there's not much there. So if you look at the equation, what could make your CO2 drop so that H plus from one side of the equation goes over because you're making the CO2 lower? Remember, this equation is in constant equilibrium, right? So if your CO2 drops because you're breathing too fast, it's going to pull H plus to the left of the equation to become H2O and CO2. So hyperventilation due to asthma, anxiety, or high altitude. So if you're anxious, sometimes you hyperventilate and you blow off the CO2 that's in your blood. If you're at a high altitude, the oxygen is at a much lower concentration, such as at the top of a mountain. You're breathing faster to get more oxygen into the system, onto your red blood cells. But in the process, you're blowing off more CO2. So you're hyperventilating. In asthma, asthmatics initially, when they're not too severe, they hyperventilate first. And when they hyperventilate, they blow off their CO2, and they produce the same issue in the bloodstream, where H plus and HCO3 combine to produce CO2. Let me correct that. CO2 is being blown off it's being lowered in the bloodstream because in mild asthma you're breathing fast, And that makes H plus and HCO3 shift over to the left side because the CO2 is dropping and this equation needs to stay in equilibrium. And if your H plus is being converted to CO2 and H2O, you're becoming alkalotic. Okay, so hyperventilation from whatever cause makes you alkalotic. So there's not many ways that you can have a respiratory alkalosis other than you breathing fast because you're anxious or you want to do it on purpose. You could try if you want. It'll typically make you dizzy. High altitude because you're breathing fast to get the oxygen in, but in the process lowering CO2. Or in mild asthma where you're just breathing fast and you're blowing off more CO2. Okay, let's look at metabolic origins of acid. So this means that the cause is within the body and not caused by the lungs. Okay, so it's everything else except the lungs is causing the metabolic acidosis or metabolic alkalosis. Okay. So let's look at a couple here of metabolic acidosis. Okay, so I remember I told you in the slide before, you're always making acids from the metabolic functioning of your body. But your body is able to clear and excrete these acids either in your kidneys or blowing off the CO2 from the equation we've been talking about in this on this slide. So what about severe diarrhea? So in severe diarrhea, what's going to happen? You're going to be hypotensive. Your blood pressure is going to be low. You're not going to perfuse your kidneys very well. And the kidneys are able to actually excrete hydrogen directly, hydrogen ions, which is acid, directly. And the other thing kidneys are able to do is they're able to make bicarbonate to buffer the acids in the bloodstream. So if you have severe diarrhea that's leading to hypotension, you're not perfusing your kidneys. And by not perfusing your kidneys, you're not able to clear the acids in your blood. And you're also not able to take advantage of bicarbonate that could be secreted into the bloodstream to buffer the acid. Okay, so any condition that makes you hypotensive or causes the kidneys not to be perfused will lead to a metabolic acidosis. Okay, so what about the next one? Kidney failure. Well, if your kidneys fail, you can't clear your acids properly. And not only that, if the kidneys fail, they're not making bicarbonate to buffer the kidney, the acid. So kidney failure, you will become acidotic very quickly, a metabolic acidosis. Diabetes mellitus, so type 1 diabetes. So DKA, diabetic ketoacidosis, is a condition. So diabetes type 1 is a condition where you have insulin deficiency. And with insulin deficiency, you start to break down the fats in your body for energy. And when you break down fats in your body, you start to produce a tremendous amount of acids. So in DKA, diabetic ketoacidosis, this is only in type 1 diabetes because it's an insulin deficiency issue where you start to break down fat for your energy because you don't have insulin to get the sugar into your cells. And in the process of breaking those fats, you're making lots and lots of acids. So you get a metabolic acidosis when you have diabetic ketoacidosis and really poorly controlled type 1 diabetes. The next one, excessive alcohol ingestion. Well, if you're ingesting large amounts of alcohol, such as a chronic alcoholic, you're not ingesting food, proteins, fats. And over time, in a chronic alcoholic, what happens is the body senses this lack of nutrition, and it depletes its glycogen stores in the liver first. You have carbohydrate storage in the form of glycogen in your liver. And then after it's depleted its glycogen stores, it's going to start to break down its fats. And when you break down fat, you get acids. You get acid byproducts. So a chronic alcoholic that has depleted all of his glycogen and is now breaking down body fat will become acidotic. Okay, it's not typically the person that goes out and drinks 6 or 7 beers. It's chronic alcoholism that does that. And starvation is the same thing. Alcohol is basically you're starving your body of food, and starvation, unfortunately, is your body is being starved of food. So the first thing to go is the glycogen in your liver that will be converted to glucose for energy. And once that is gone, typically in 3 to 4 days, your body will then revert to fat breakdown in the body. So if you have a lot of fat reserves, it will use the fat reserves as energy that it will break down and convert. So the body can convert fat stores into sugar through different pathways, but in the process making lots of acids, and you will become acidotic with starvation. Okay, and then the last part of the breakdown process, if you've consumed all your fats, the body will often start to break down protein. It's the last thing it has to feed itself. So it'll break down protein, but it really doesn't want to break down protein unless it has to, because protein is what your muscles consist of. And once you start to break down your proteins significantly, then you lose the ability, you become extremely weak, you lose the ability to walk, you become bedridden. So typically it's carbohydrate, then fat breakdown, and then protein breakdown. Okay, metabolic origins of alkalosis. Okay, so let's go to a couple of these. As I said, alkalosis is not a very common scenario compared to acidosis. I'll just go over a couple of these. Ingestion of excessive sodium bicarbonate. Well, if you make a mixture of sodium bicarbonate, which will then turn into bicarbonate, HCO3, that's going to buffer the acid in your bloodstream, the H+, and it'll shift you to an alkalotic state. So if you like making bicarbonate antacids at home, so you make your own solution and you drink tremendous amounts of bicarbonate, you will become alkalotic, a metabolic alkalosis. What about severe vomiting? Well, severe vomiting, your stomach is filled with acid, H+. So if you are repetitively vomiting, your stomach tries to replace the H+ by secreting more of it into the stomach lumen, and you continue to vomit it up. So you're losing a lot of H+, and you're becoming alkalotic. And the last one I'll just mention, diuretics that cause potassium depletion. So if you deplete your potassium in your serum because you are on a very powerful diuretic, say, this will come up in another part of the talk anyways. So if you become hypokalemic, the cells will say, okay, we're going to move some potassium out of the cells because we can see that the serum and the interstitial fluid is low on potassium, so we'll move some potassium out of the cells. But in order to do that, we have to trade off with taking a hydrogen ion into the cell. So it's the potassium hydrogen pump. So by doing that, you're actually moving hydrogen ions intracellularly, so the serum pH will go up. You'll become alkalotic in hypokalemia. Okay. Okay, so let's look at one of the drugs that we have available to us, sodium bicarbonate. So what can we use sodium bicarbonate for? So remember, bicarbonate is the buffering molecule for H plus in the blood, and H plus is acid. So we can use it in any condition where you have metabolic acidosis. So say, for example, someone has diabetic ketoacidosis. So they haven't taken their insulin for a day, and when you don't take your insulin in type 1 diabetes, the insulin drops to 0. When the insulin drops to 0, you cannot have glucose go into your cells because that's what insulin does. So the body senses the fact that it doesn't have glucose to get into the cells. It has lots of glucose in the bloodstream, it just can't get into the cells. And that's why DKA is actually called starvation in the face of plenty. So the cells are starving because they can't get the glucose in due to lack of insulin, but the bloodstream is full of sugar, of glucose. So what happens when you have absence of insulin? The fats start to break down, and you to come to the rescue to give energy to the cells, but in the process make lots of acids in the bloodstream. And when you make lots of acids in the bloodstream, your pH drops, and when your pH drops, you get sick very quickly. A metabolic acidosis can be deadly quickly. So, and why is it deadly quickly? Well, we'll talk about that at some point. But because all the enzyme processes and all the metabolic processes are reliant on normal pH, they start to malfunction. The other thing that happens in metabolic acidosis is you become hyperkalemic. Your potassium climbs very quickly. And when you're hyperkalemic, your cardiac function, the electrical conduction in your heart, becomes very irregular, and you get dangerous arrhythmias with hyperkalemia. Okay, so an acidosis from any cause is very concerning, and we want to correct it quickly. Unfortunately, the way we correct it is not by typically infusing sodium bicarbonate, because that's not treating the underlying cause. That's just a reaction that's, the sodium bicarbonate is combining, or the bicarbonate is combining with the H plus and turning it into H2O and CO2, but the underlying disease, whatever's happening, hasn't been corrected by the sodium bicarbonate. So we don't use it as often any longer. It's available, but we don't use it for metabolic acidosis very often. What we do is we try to correct the underlying disease process. So for example, if it's diabetic ketoacidosis, we give insulin, we give IV fluids to correct the underlying disease process. If it's metabolic acidosis from renal failure, well, either we try to correct kidney function or they need dialysis. Okay, and that will correct the acidosis. So sodium bicarbonate can be used to help out a bit, but it's just a bridging medication. It's just a bridging drug until we can treat, and we really want to treat the underlying cause first. Okay, hyperkalemia. So why could I use? So if I get a patient come in and we notice that their potassium is 7.8, one of the drugs, we go for a number of drugs, but one of them is sodium bicarbonate, intravenous sodium bicarbonate. And why is that? If we give bicarbonate intravenously, we will cause H plus to combine with it, which is going to elevate the pH in the blood. So as your hydrogen ions are soaked up by the bicarbonate, the hydrogen ions in the cell are going to come out of the cell because we're lowering serum H plus. And what happens when we have H plus come out of the cell into the interstitial fluid? We have potassium go into the cell with that hydrogen potassium pump. So we can give bicarbonate that will soak up H plus in the bloodstream, which will lower the H plus in the bloodstream and make it alkalotic, will make the bloodstream alkalotic. The cells throughout your entire body will give up some hydrogen ions and move them from intracellular to extracellular. But in the process, they have to trade by taking a potassium into the cell. So we lower serum potassium temporarily by using sodium bicarbonate because we hide the potassium in the cells. Because the first thing we want to do if someone is really hyperkalemic is get the potassium down now. Okay? And so sodium bicarbonate is one of the medications that we can use to get the serum potassium down now. Salbutamol is another one, or albuterol, and insulin we also use in combination with a dextrose infusion. So let's clear this up a bit. Someone comes in with a potassium of 7.8. Okay. We give them an albuterol nebulizer, a mask of albuterol. That's a beta-2 agonist that causes, that beta-2 agonists cause potassium to go into the cells temporarily. We give them 1 to 2 amps of bicarbonate, and that causes potassium to go into the cells. We give them insulin in combination with a glucose drip, a dextrose drip, and insulin also causes potassium to go into the cells. So all those three measures that we just mentioned are to hide the potassium temporarily. It's still going to come back out if we stop giving these drugs. So what we really want to do is flush the potassium out with IV fluids, and sometimes even with diuretics to get the potassium out in the urine, and also correct the underlying condition that's causing the hyperkalemia. Okay. The other thing sodium bicarbonate is used for is to make the urine alkaline. So if we give intravenous sodium bicarbonate, it's going to make your bloodstream alkalotic. So in your urine, your body's going to say, well, I don't want all this bicarbonate. I don't need it all. So I'm going to make my urine alkalotic, which some drugs in overdoses, such as TCAs, aspirin, phenobarbital, they are excreted much better in alkalotic urine. So we alkalize urine, or we alkalize the serum so that some drugs, the tricyclic antidepressants, acetylsalicylic acid, aspirin, and phenobarbital are excreted much better into the urine. Okay, so how does it work? It's a buffer. HCO3 is a buffer, right? It can soak up hydrogen ions, which is acid, and help raise the pH. Adverse effects. Well, if you give too much, you'll cause a metabolic alkalosis. And that would be unusual. You would have to give a lot to cause a metabolic alkalosis, but it's possible. And by causing a metabolic alkalosis, you can get some confusion and irritability. Look at the slow respiratory rate. Well, if you've made an alkalosis, okay, you're actually, if you think of that equation we did slides ago, you're actually soaking up hydrogen ions. So the equation is going to move from CO2 and shift it to H plus and HCO3. So you don't need to breathe as fast because you've given a drug that's soaking up the acids that could have been breathed off as CO2, but doesn't need to be now. So your respiratory rate slows down. Contraindications. So vomiting and GI suction with an NG tube are essentially the same thing. You're sucking up acids from the stomach. So you're either vomiting them up or you're suctioning them up. And you're already alkalotic if you're doing that. So you wouldn't want to make someone more alkalotic with sodium bicarbonate. Oh, and by the way, one of the adverse effects of giving too much sodium bicarbonate is you can give someone a lot of sodium, right? Because the bicarbonate comes in the form of sodium bicarbonate. So you can elevate their serum sodium. Okay. And the last one, severe diarrhea. You can become acidotic with severe diarrhea. And don't forget, what are you losing in diarrhea? You're losing tremendous amounts of fluid, and you're losing tremendous amounts of electrolytes, right? So sodium, chloride, and potassium. I think the most important ones for contraindications would be vomiting and GI suction, which are essentially the same thing, really, because they really cause alkalosis. So nursing responsibilities, in and outs, electrolytes for sure. So input and output, because this is often happening in something where people are losing or are being given IV fluids, and they're losing fluids in some form. So ins and outs are important. Electrolytes for sure. If you're giving bicarbonate, you could potentially shift potassium. You're altering the pH, so you need a blood gas. And baking soda, nursing responsibilities, baking soda. I'm not clear on that one. Maybe to check to see if they're taking baking soda. I'm not clear on that last baking soda one. Okay, so let's look at a medication that's the opposite of sodium bicarbonate, ammonium chloride, or ascorbic acid, which is vitamin C. Well, these are acidifying agents. So they're mild acids, and when they're given intravenously, they can acidify the blood. Why would we ever want to acidify someone's blood? Well, the main reason, well, first of all, it wouldn't be very common, but the main reason is in certain overdoses, such as amphetamines, you can acidify the blood so that the amphetamines get excreted quickly in the urine. Okay. People acidify they take acidifying drinks all the time to try and treat urinary infections. So cranberry juice, well, that has vitamin C in it. Apple juice, a lot of apple juice has vitamin C. So that acidifies the urine, and bacteria do not like to live in acidic urine. And that's the reason why people are often told to take cranberry juice. Unfortunately, some cranberry juices don't have vitamin C in them, and that goes for apple juice as well. Metabolic alkalosis. So if you have a condition, remember there's not many conditions that give you a metabolic alkalosis. And typically you're going to correct the underlying condition as opposed to giving ammonium chloride. So if you're vomiting profusely and you have metabolic alkalosis because you're vomiting, we're not going to give ammonium chloride. We're going to correct the vomiting with anti-nauseants, IV fluids. So, I mean, you can think of it as a drug that can be used to treat metabolic alkalosis, but typically when you have metabolic alkalosis, another reason would be, say you're anxious, you're having a panic attack, you're breathing fast, you're blowing off your CO2, and that's causing you to be alkalotic. We usually correct the underlying panic attack as opposed to giving ammonium chloride. So what's the action of this drug? So it'll reduce alkalinity. So it'll reduce your pH, since this reacts with bicarbonate. It'll lower your pH. So your pH was too high. This will lower it. Adverse effects. Well, acidosis if you give too much. CNS depression is from being acidotic. And nausea and vomiting can be from acidosis as well. So I wouldn't think of this as a very common drug. Remember, we treat the underlying conditions for acidosis and alkalosis. Contraindications, hepatic and renal failure. So if you have renal failure, you probably have metabolic acidosis. You would definitely not want to give another acid, such as ammonium chloride. If you have any other kind of acidosis, such as a respiratory condition, COPD, asthma, pneumonia, hypoventilation from a drug overdose, you already have respiratory acidosis. You'd never give someone another acid in the form of ammonium chloride. Or a metabolic acidosis from anything. You would aggravate it by giving this drug. Okay. So the same thing would go if you were administering this drug. It would be given slowly due to the chance of overshooting and causing a metabolic acidosis. You'd monitor arterial blood gases, which gives you an idea of course, the pH as well. You'd monitor electrolytes in your labs. And definitely we monitor cardiac rhythm with patients that are either severely acidotic or alkalotic, right? Because acidosis and alkalosis messes with your potassium, right? They trade off and shift between intracellular and extracellular compartments. So, changes in pH, meaning changes in hydrogen ions or alkalosis, can mess with serum potassium. Okay, so there's a couple of terms that it's a good idea to know. So reabsorption means that you have fluid that's in your nephrons that's been filtered at the glomerulus, and you have electrolytes and water in your nephron, and when it is reabsorbed back into the bloodstream, that's called reabsorption. Okay, so it's from the renal tubule, or the nephron back into the bloodstream is reabsorption. What's secretion? Secretion is where capillaries can secrete. This is after the glomerulus, by the way. They can still secrete electrolytes and other chemicals from capillaries into the nephron. That is secretion. So that's the other direction. Excretion just means that you're getting rid of it. It's going into the urine. So it's going out. So understand, so I would actually, the one term that I would add here is secretion. Reabsorption means it's coming from the most things that you filter in your nephron are reabsorbed back into the blood. So your body doesn't get too nervous about filtering a lot of electrolytes and water into the nephrons of your kidneys, because it knows it can get it back by reabsorption. And it knows it can also get rid of more things by secretion into the nephrons. Okay? And the balance between those two processes, reabsorption and secretion, you'll end up with the final product that you excrete into the urine. The second image here is just showing how a diuretic works. Okay, so something like furosemide, a loop diuretic, it blocks reabsorption of sodium ions, potassium ions, and chloride ions. So they continue into the urine, and wherever sodium goes, water follows. So you get a diuretic effect because you've blocked sodium reabsorption. Okay, what's reabsorption? The body is getting back fluids and electrolytes from the nephrons. It's reabsorbing it. What's secretion? The body is getting rid of fluids or electrolytes or whatever else it wants to get rid of into the nephron. Secretion. What's excretion? The overall process of the final product that's in the urine is excretion. Okay, so let's look at some nephrotoxic drugs. So drugs that when given, we typically monitor the kidney function because we know that, having used these drugs for years, that they're tough on the kidneys. And it's not like you need to memorize all of these. It's just to give you an idea of some drugs that are nephrotoxic. They cause injury to the kidneys. Okay, so definitely aminoglycoside antibiotics. You're going to hear this again and again. Aminoglycosides are a group of antibiotics. Gentamicin, tobramycin would be very common aminoglycosides that are given for bacterial infections, and they're toxic. They're toxic to the kidneys. So we keep a very close eye on kidney function tests with them. Amphotericin B is a intravenous antifungal. Aminoglycosides are intravenous, by the way, as well. Amphotericin B is an intravenous antifungal medication for severe systemic fungal infections. This is an unfriendly drug with a lot of side effects, and we'll either discuss it or it's been discussed in the past. And angiotensin converting enzyme inhibitors. So they're used all the time for hypertension and heart failure. They can be hard on the kidneys, and we're careful with them. They can cause hyperkalemia, so high potassium. We'll discuss these more later. And they can, in the setting of weak kidneys, they can definitely cause hyperkalemia. Cisplatin, carboplatin, those are just chemotherapy agents. really tough on the kidneys. Cyclosporin and tacrolimus, they're in the same group. They're immunosuppressants for organ transplantation. They're calcineurin inhibitors. Okay. Foscarnet, that's not. We won't go into detail there. Non-steroidal anti-inflammatories. That's an important group to know because they're so common. Ibuprofen, naproxen, diclofenac, all those medications that people take for inflammation. So ibuprofen being the prototype one. They're really hard on a number of systems. So if you see NSAID, non-steroidal anti-inflammatory drug, it's going to be hard on the stomach. It's going to cause hypertension temporarily, and it's very hard on people that have kidney disease. It aggravates renal failure. So we're super careful in the older people with non-steroidal anti-inflammatory drugs. Pentamidine, we'll skip over that. It's not that important. Radiographic intravenous contrast agents. So we use dyes to enhance certain parts of the body when we're doing CAT scans, for example. And so we'll inject a dye, and then we'll either do a CAT scan or an MRI to look at that organ that we're trying to get good images of. The contrast dye can be harmful to the kidneys. Okay, so people with weakened kidneys already, we're extremely careful with contrast agents during diagnostic tests. Okay, so this slide we've seen before. Under osmotic diuretics, you can put mannitol. Under carbonic anhydrase inhibitors, you can put acetazolamide. Under loop diuretics, you can put furosemide and bumetanide. Under thiazide diuretics, you can put hydrochlorothiazide. Under potassium-sparing diuretics, you can put spironolactone, you can put triamterene, and you can put amiluride. And we'll get to those. Okay, so just have an idea. All these diuretics, they're pretty cool. They work in different parts of the nephron. So let's start with a diuretic here, hydrochlorothiazide. And remember, this is in the thiazide diuretics. So if you remember that image of the nephron, this falls into the thiazide diuretics. There's other ones that are similar to it, but really this is the prototype one, hydrochlorothiazide. And it works on the distal convoluted tubule. So if you recall that if it works further down the nephron, it just doesn't have as much diuretic effect. Which is good, because if it has tremendous diuretic effect, you really can't use it on a day-to-day basis. And this one you can. It's often used for hypertension. It's actually first line. It's one of the first line medications for hypertension. It's used for peripheral edema, so swelling in your legs. We can use it for ascites, which is fluid from back up in the setting of cirrhosis, typically. So we can do it. We can use it to help drain, eliminate some ascites fluid. It can be used in congestive heart failure. Congestive heart failure is a condition where you have fluid excess. So the heart is unable to pump the fluid that is coming to the left ventricle or the right ventricle, and you have fluid backup. So diuretics are often used in congestive heart failure. Furosemide much more than hydrochlorothiazide, since it has more power. Nephrotic syndrome is a condition where you're losing tremendous amounts of protein. That's actually the definition of nephrotic syndrome, excessive loss of albumin. And in order to help remove some of the fluid that you're retaining, you can use hydrochlorothiazide. But in general, number one, hypertension and peripheral edema, and sometimes in congestive heart failure, although it's not that strong for congestive heart failure. So it decreases reabsorption of sodium at the distal convoluted tubule. And of course, if sodium isn't reabsorbed, water isn't either, and out they go into the urine. So what are the effects? Well, you can definitely get hypotension. It's draining you of fluid. You can get orthostatic hypotension, meaning when you stand up too quickly, the body is slightly dehydrated from the diuretic. So when you stand up too quickly, the blood pressure drops temporarily. Hyperglycemia can be an effect of hydrochlorothiazide. The reasons for why it causes hyperglycemia isn't really understood. It's felt that the drug somehow causes some insulin resistance, meaning that insulin isn't as effective, so glucose doesn't get into the cells as easily, so it can give some hyperglycemia. Dizziness is purely just from the potential low blood pressure. Electrolyte imbalance, well, it's draining sodium, it's draining potassium, and it's draining chloride. So you can get hyponatremia, hypokalemia, which is listed there. So what are the contraindications? Well, anuria means you're not making urine. So if you're not making urine, a diuretic won't work because your kidneys aren't working. So it won't have any effect to produce more urine since you're not making any. And if you're not making urine, you're usually on dialysis. So your diuretics aren't effective since the kidneys are non-functioning. Sulfa sensitivity. So the molecule of hydrochlorothiazide has some similarities to a sulfa, to the sulfa molecule. And if you remember, sulfa is a type of antibiotic. So there's some potential for cross-reactivity between hydrochlorothiazide and a sulfa allergy. If you're already hypovolemic, such as dehydration, you'd never add a diuretic to someone who's dehydrated. And also a history of gout. So why would you not use this with a history of gout? Well, thiazide diuretics cause an elevation of uric acid in the bloodstream. And uric acid is the chemical in the bloodstream that leads to gout in joints, so inflammation in the joints from uric acid. So if someone has a history of gout, hydrochlorothiazide would be avoided. Okay, so anuria is a good thing to remember. Like, if you don't make urine, no diuretics will work, right? So if you're on dialysis, you wouldn't be on diuretics since your kidneys are non-functioning, and that's why you're on dialysis. Okay, nursing responsibilities. Well, definitely if you're using a diuretic, ins and outs are really important. How much is someone receiving as IV fluids, oral fluids, and then how much output is there? Daily weights is often important. Someone with congestive heart failure where we're removing fluid from their system with diuretics, we want to know their daily weights to see how many pounds they're losing per day or per week. Vital signs, because this can cause hypotension. Blood sugar check, since it can cause some elevation of your blood sugar. Labs for electrolytes, since it can drain sodium, chloride, and potassium. And other ones too, some more uncommon ones like calcium and magnesium as well. And diet, discussing a potassium-rich diet so that you don't become hypokalemic. Okay, so let's look at another group here, the potassium-sparing diuretics. Okay, so they're still diuretics, but what they do is they don't drain the system of potassium, which can be good and bad, depending on what other drugs they're on and other conditions that people have. So spironolactone would definitely be the prototype. Eplerenone is really just a new spironolactone. It would be much more expensive. And there's two others in the group, triamterene and amiloride, and they all create diuretic effects, meaning produce or diurese the system by producing more urine, but they don't drain potassium from the system. Okay, so how does spironolactone do that, and eplerenone? Well, they're aldosterone blockers. Okay, so if you can think of what aldosterone does, it reabsorbs sodium and excretes potassium. Well, if they block spironolactone in the distal tubules and the collecting ducts, well, you don't reabsorb sodium, but you don't secrete potassium. Okay, so by not reabsorbing sodium in the collecting ducts and the distal tubules, you create a diuretic effect. So it's still a diuretic. Not as powerful as a loop diuretic because of where it's working. So what are the indications for spironolactone or eplerenone? Or even the other ones, triamterene and amiloride, for example, are used commonly in diuretics. In blood pressure medications. Uh, they have diuretic effects and they don't drain you of potassium. Spironolactone or eplerenone, they're used in congestive heart failure to drain the system of some fluid so that there's less fluid stress or volume stress on the heart. And they are often used in the setting of ascites to drain some of the ascites fluid in the setting of cirrhosis. You can also use any of these, as I mentioned before, for hypertension. So they can be add-on medications for hypertension. And nephrotic syndrome is a state of diffuse edema in the body from losing so much protein in the kidneys. So how does spironolactone and eplerenone work? Well, blocking aldosterone in the distal tubules and collecting ducts. Okay, so what's the side effect? Well, you can have some bad side effects to spironolactone or eplerenone. Hyperkalemia, right? Because it's blocking potassium from being secreted. And it's blocking sodium from being reabsorbed. So hyperkalemia can be a side effect of spironolactone. And if you have hyperkalemia, then dysrhythmia is of course going to be a side effect, since high potassium can give you dangerous arrhythmias. Urinary frequency, well, any diuretic is going to give you urinary frequency and dehydration. Since it's a diuretic, we could dehydrate you. We could cause hypotension with diuretics. Hormonal changes and gynecomastia. So gynecomastia is small breasts in males, and spironolactone has some hormonal effects. It can stimulate the male breasts to enlarge. So because spironolactone can block testosterone effects, you can, in males, if you block testosterone effects, then you'll get a bit more estrogen effects because you've tipped the balance towards the little bit of estrogen that males have, and you'll get a bit of gynecomastia. Okay. If you stop spironolactone, this will typically go away in 6 months to a year, so it's not permanent. Eplerenone came out because it doesn't tend to cause gynecomastia. So compared to spironolactone, you have less of a chance of getting gynecomastia. Okay, so contraindications. If you have any reason to have hyperkalemia, you would not take these drugs. It could make it much worse. Severe renal failure. Well, if you have renal failure, you have a good chance of already having hyperkalemia, because that's one of the main causes of hyperkalemia is kidney failure. You're not able to get rid of your potassium. Again, there's anuria. We don't use diuretics if you don't make urine. And of course, pregnancy and breastfeeding, because this messes with testosterone, it alters hormones a bit, then spironolactone would not be used in pregnancy and breastfeeding. And the same nursing responsibilities as other diuretics: input and output, daily weights, vital signs, monitoring labs, and of course discussing a diet. So we typically tell people to avoid potassium supplements, to be careful with excessive potassium. We often tell people that are on diuretics not to drink fluids too much. If you drink too many, if you consume large amounts of fluids, you're just going to overwhelm the diuretic effects, no matter which diuretic that you're on. Okay, so let's migrate to a drug that isn't used very often except in certain emergencies, and it's an osmotic diuretic. It's very close, it works very close to the glomerulus. So you can imagine the effect it has when it's immediately affecting the filtrate right from the glomerulus. If it can stop reabsorption of fluid, then it'll have a tremendous diuretic effect. So what are the indications? So look at the indications here. Reduce intracranial pressure. So that is usually in the setting of a head injury, something that has caused the pressure in your brain to increase significantly. And the most common reason is usually head trauma. The other indication is intraocular pressure. So increased intraocular pressure, meaning acute glaucoma. So that's an acute glaucoma is an emergency. And we need to take fluid. Well, we need to reduce the pressure in the eye, or in the setting of intracranial pressure, reduce the pressure in the head very, very quickly. And we use a drug called mannitol in an emergency setting. And basically what it does is it pulls fluid from cells and interstitial fluid, and it pulls it back into the bloodstream. And then at the kidney, it acts as a very, very strong diuretic by keeping things in the nephron, and they don't get reabsorbed. Okay, so mannitol is just a type of sugar. So mannitol is a sugar, sorbitol is a sugar. There's all kinds of sugars. So it's just a big sugar molecule that can have tremendous osmotic diuretic effects. So think of it as having the ability to pull some fluid out of the eyeball, drain some fluid out of the eye to reduce the pressure in the eye, pull fluid out of the cells and the interstitial fluid of the brain, and then when it acts on the kidney, it takes fluid, it keeps water with it because it's a large sugar molecule, and it flushes it has a huge diuretic effect out into the urine. Okay, so you can imagine it has tremendous electrolyte abnormalities. It can cause hypovolemia because of the massive diuresis it causes. Dizziness is just from the hypovolemia. It can cause heart failure, and it can cause shock. So how can it cause shock? So if it has a huge diuretic effect and it's draining you of fluids, that's going to lead to hypovolemia, and that can lead to a shock state. So when would you want to avoid mannitol? Well, again, if you're not making urine or your kidneys aren't functioning and urea, there's no sense in using mannitol. Heart failure. So when we initially give mannitol, it's pulling massive amounts of fluid out of cells and interstitial fluid back into the vascular system before it has its diuretic effect. And that can lead to fluid overload in the vascular system initially. So if you have heart failure, it can aggravate your heart failure. Okay, just because it's pulling all this fluid back into the vascular system prior to having its diuretic effect. Intracranial bleed, well, if you can imagine that there's a whole bunch of blood vessels on top of the brain and throughout the brain, when you pull fluid, when you suck fluid from cells in the interstitial fluid, you're actually trying to shrink the brain, and that can cause some bleeding in the small vessels within the brain by trying to shrink the swelling and the edema within the brain. Severe dehydration, you'd obviously never use this, right? You're going to get a massive diuretic effect and you'll get more dehydrated. And shock, we would never use this, right? Because someone in shock is already hypotensive, and this will make them more hypotensive. Nursing responsibility, definitely ins and outs. This is usually an emergency room setting or the ICU. Daily weights, although they wouldn't be on this for that long usually. Vital signs for sure. Labs such as electrolytes, and mental status changes. We're typically giving this for someone who has had a massive head injury and is semi-comatose, obtunded, unconscious. So we're going to constantly monitor their mental status to see if it's improving with the mannitol or they're getting worse because of the injury. Okay, so this is an image showing monitoring of intracerebral or intracranial pressure with a probe that they've inserted into the ventricle of the brain, the bottom right. So it's an ICP bolt. And someone with a severe head injury sometimes needs this inserted by a neurosurgeon to monitor the intracranial or intracerebral pressure, so that they can adjust medications based on how severe the pressures are. Okay, so mannitol is sometimes used, but remember it's a bit of a double-edged sword. It takes fluid away from the brain, away from the cells of the brain, but it has a lot of effects such as a massive diuretic effect, electrolyte shifts, hypotension later, once you've drained all this fluid away. So it's not a drug someone would go home on at all. This is definitely an ER ICU type drug. So the next medication we're going to look at is acetazolamide. We're not going to spend too much time on this. The brand name is Diamox. And again, when you look at that image of the nephron, you'll see that it acts very close to at the proximal tubule, so it's going to have a tremendous diuretic effect. So we can still use it in an emergency such as acute closed-angle glaucoma. Um, it is also used in motion sickness, high altitude mountain sickness, and increased intracranial pressure. And I think that's how I would think of the medication, that it's a powerful diuretic. It can be used in acute glaucoma. It can be used in increased intracranial pressure, just like mannitol. And it's sometimes used in high altitude mountain sickness. I don't think the other ones are that important, metabolic alkalosis, because it's already a very rare condition, metabolic alkalosis. So how does it work? Well, it inhibits this enzyme called carbonic anhydrase. So it inhibits carbonic anhydrase excreting sodium and bicarbonate. Okay, so by excreting sodium and bicarbonate, it has this diuretic effect. And it also reduces the aqueous humor, which is the fluid in the eye itself, and lowers intraocular pressure, IOP. Okay. So what would be so if you look at those adverse effects for acetazolamide, so say someone comes in and they have acute glaucoma, and we want to treat them with acetazolamide. Which side effect would be most concerning? Well, we know any diuretic is going to have some electrolyte imbalances, okay? Nausea, vomiting, and diarrhea, most drugs can do that. Look at the first one, metabolic acidosis. So, because of the way it works, it can lead to a metabolic acidosis. And we know how much the body dislikes changes in the pH. So that would be one to remember for this drug, that it can cause a metabolic acidosis. Okay. Contraindications, sulfa and thiazide sensitivity. Just because it's a similar molecule, there's some similarities to it, to sulfa and also thiazide. Remember the thiazides were similar to sulfa? Well, this is also similar to them, so that there can be a cross-reactivity. And of course, in severe renal or liver failure, you couldn't really use an extremely powerful diuretic such as this. Okay, and look at the nursing responsibilities. They're very similar to other diuretics. So think of this as an emergency type drug. Definitely not one that you receive at home. This is for head trauma and acute closed angle glaucoma of the eye. So let's look at some electrolytes a bit, and these are difficult to remember because they all kind of start to sound similar. The side effects and sodium, potassium, and calcium, they all start to have similar effects. So what we're looking at here is if the sodium is beyond 145 in the serum, that's hypernatremia. And if it's lower than 135, and that's hyponatremia. Now I know for exam purposes, if it's 134, then you should consider it hyponatremia. And if it's greater than 145, such as 146, then it would be hypernatremia. In real life, we wouldn't be worried about a slightly low or a slightly elevated sodium, but that's probably not the case for exam purposes. So just know those numbers. So sodium abnormalities typically affect the neurological system. Okay, so let's just look at that. So try to link one system to each electrolyte. So sodium, neurological symptoms. So if your sodium is slightly elevated, so above 145, you're going to be thirsty, right? You're triggering your chemoreceptors and and osmoreceptors, and they're going to get you to drink because you're thirsty. You're getting weak. So there's some weakness, there's some confusion. These are neurological symptoms and muscular. So severe hypernatremia, muscle twitching, right? Those action potentials aren't working as well anymore. because the sodium is just too high. Confusion, so mental status changes. Cerebral hemorrhage. So think of you have very salty blood, and that's going to pull fluid. That's going to pull some fluid out of the interstitial and the intracellular. It's going to shrink. It's going to shrink your brain. So as it shrinks the brain, you can get small cerebral hemorrhages. You're going to get confusion because the cell is shifting into the intravascular space because the sodium is elevated. Okay, we actually use a solution called 3% normal saline, and we'll talk about that later. And all it is very salty water in certain brain conditions. Hyponatremia. Okay, so your sodium is less than 135. So as it drops, you're going to get some mental status changes, headaches. Why? Well, so your serum is low on sodium, more on water. So the water is going to go to a higher concentration, such as in your cells of the brain, and you can get some cerebral edema. So you're going to get headaches. You're going to be off balance. You're going to be fatigued because the fluid from the vascular space can now flow into the cerebral cells and cause cerebral edema, right? So look at when it's severe, confusion, loss of consciousness. So you're getting brain edema here. Seizures, death, coma. That's not good. Okay? So think of sodium as really, most of them are neurological effects. Okay, let's move on to potassium. A little review here. So potassium, remember, it's the main intracellular electrolyte, just like sodium is the main extracellular electrolyte. The range in the serum is 3.5 to 5 for potassium. And abnormalities in potassium levels, whether they're high or low, will typically have their effects on the heart. So really, if you hear hyperkalemia, which you are going to hear many, many times in the coming semesters, think of heart arrhythmias. That's why high potassium is one of the most concerning electrolyte abnormalities that we have to deal with, because we know it kills people from cardiac arrhythmias. Okay, so hyperkalemia, we will see electrocardiogram changes when we do a 12-lead electrocardiogram. We can see all kinds of arrhythmias or dysrhythmias. They mean the same thing. People can get palpitations. They can go into very dangerous ventricular rhythms, and finally into cardiac arrest. Okay. The other thing to think of with potassium, so the first thing to think of is always, heart. High potassium, heart issues, arrhythmias. You can get muscular issues with high potassium as well. They're not as important, but you can get muscular cramps. And when we look at hypokalemia, you're going to see, again, what's the main issue? Arrhythmias of the heart. Irregular rhythm, slow, fast rhythm. So a tachycardia is a fast rhythm. A bradycardia, slow rhythm. But you can also get some leg cramps, some muscular leg cramps, some weakness. And then, of course, the end stage of any arrhythmia, cardiac arrest. So really you have to think of heart when it comes to potassium. Okay, especially high potassium. There's many things that cause high potassium, and that'll be discussed elsewhere. And there's many things that cause low potassium. And in particular, one of the most common that we're discussing in this module is diuretics, right? We drain people's electrolytes with diuretics. All right, so the next electrolyte is calcium. The normal level is 9 to 10.5. So hypercalcemia, there's a pretty simple mnemonic for hypercalcemia: high serum calcium. And the one, I'm not a big fan of mnemonics because that means I'm memorizing something, and I try my best not to memorize because it just doesn't last very long, unfortunately. So stones, so here's the mnemonic for you, if you like mnemonics: stones, bones, abdominal moans, and psychiatric overtones. So stones meaning if you have high calcium in your blood, you can get kidney stones. Bones meaning you're likely getting all this calcium from your bones, so you're getting osteoporosis. You're draining your bones of calcium, so you're weakening your bones. You get abdominal discomfort and abdominal cramps with high calcium, so abdominal moans, and psychiatric overtones. You get depression with high calcium. So that's just a simple mnemonic for hypercalcemia. In general, I mean, calcium's a bit of a mixture of a lot of things, like muscle weakness, when your calcium is elevated, diminished deep tendon reflexes. So when your calcium is elevated, you're not really twitchy like you are with hypocalcemia in a minute that we'll see. So they're more relaxed, the reflexes. You're depressed. You develop calcium kidney stones, and potentially abnormal heart rhythms. Hypocalcemia, you're more twitchy. It's more of the twitchy side, the twitchy effects. So convulsions, seizures, arrhythmias, spasms of the muscles, positive Chopsticks, Chopstick sign and Trousseau sign, and those are tests for looking at twitchy muscles of the face or at the spasms at the wrist. Okay, increased deep tendon reflexes and seizures. So think of hypocalcemia as the body is getting really nervous and twitchy of the nervous system and the muscular system. So we're going to be talking about intravenous solutions, and there's two broad categories of intravenous solutions. There's crystalloid solutions they're essentially just made of crystals of electrolytes and sugar. So those are the crystalloids. And then the colloids, which are solutions less frequently used, but they consist of large molecules that are suspended in the solution. And they're used for specific circumstances. So on this slide, let's start with crystalloids. And crystalloids come in three forms: hypotonic, isotonic, and hypertonic. And the term tonicity just refers to the amount of dissolved solutes within the solution. So if something has a high tonicity, it means it has a lot of solutes within the solution. So it's, say for example, very salty because it has a lot of NaCl, sodium chloride, in it. If it's hypotonic, it'll have less solutes. And this is all compared to the intracellular compartment of the body. So let's look at the three groups. Hypotonic solutions. So that's a solution that has lower total electrolyte and sugar content in general, causing the tonicity to be lower than the intracellular compartment. So hypotonic solutions will tend, the fluid in hypotonic solutions will tend to leave the vascular space and go to the intracellular space and cause cellular edema, okay, and peripheral edema as well. Since the cells have higher tonicity, higher concentration of electrolytes, the water component of these IV solutions will migrate there. Isotonic solutions mean that the osmotic pressure of these solutions are very similar to the intracellular compartment. So there won't be the same fluid shifts from the IV fluid solution that's being given into the intracellular compartment. An example of these would be 0.9% normal saline or lactated ringers. Hypertonic solutions tend to have more dissolved solutes. So whether it's NaCl, such as 3% normal saline, or they have higher concentrations of dextrose, such as D10W, they're hypertonic. So this will cause cells to shift the fluid within the cells into the vascular space temporarily and shrink the intracellular compartment. It'll move fluid out of the cells. Okay, and this will come into play when we start to discuss different conditions. So in general, isotonic solutions are by far the most common solutions we use for rehydration of patients that are dehydrated or are hypotensive, because they tend not to shift into the intracellular compartment. So we don't want to be dealing with a lot of shifting of electrolytes and fluids. So hypotonic solutions, I would say, tend to be used least often, and hypertonic solutions are sometimes used in certain conditions, and we'll get to those. Okay, so we're still talking about crystalloids, okay, and the three different groups that crystalloid solutions, those IV bags that you see hanging in hospitals, come in: hypotonic, isotonic, and hypertonic. So let's do the hypotonic. So there's less dissolved solutes in the IV bag than intracellular compartment of the body. And a good example of that would be half normal saline, which is 0.45% normal saline. Okay. The other ones we won't get into, they're not very common. And this causes fluid to shift from the vascular space where the IV fluids are being given into the cells. It'll cause cellular edema. So if the only part of your body that was dehydrated were your cells, this would be a good solution. But typically things don't work that way. You tend to have overall dehydration. It's not like you have cellular dehydration by itself very often. So we do watch out when we're giving these fluids for decreased blood pressure. And why is that? Well, the fluid is shifting out of the vascular space with these hypotonic solutions. So they won't be great solutions to maintain someone's blood pressure. The lower part of the hypertonic section, when wouldn't you give it? Well, in low blood pressure, not going to be very helpful since the fluid shifts out to go to the cells. Increased intracerebral pressure. Well, again, the fluid's going to shift into the cells of the brain as well, which is going to cause more pressure in the brain. So we would never use these in, say, a patient with a stroke, a patient that's had trauma and is hypotensive, someone who's been burned and is leaking tremendous amounts of fluid, and they're likely hypotensive. Hypotonic solutions leave the vascular space, so they won't be very useful. Isotonic solutions are similar to have the similar concentration of solutes as the intracellular compartment. So that would be 0.9 normal saline. Lactated ringers. D5W is a weird one. As soon as you give D5W as a solution, the body immediately takes the dextrose and consumes it, so now you're left with water, and it becomes hypotonic. So in general, we tend to consider D5W, maybe initially it's an isotonic solution, but it quickly becomes hypotonic since the dextrose is taken away. There's no big fluid shifts with isotonic solutions, and we use this group by far the most commonly, especially for fluid and electrolyte replacement or maintenance fluids for someone who has to be on IV fluids for days, or someone who comes in severely dehydrated or heat stroke. We will use lactated ringers or normal saline. We do tend to watch for fluid overload. Since some of this fluid is staying in the vascular space, you can overload a patient, vascular overload, and you can put some people into congestive heart failure. Some of it, of course, goes into the interstitial space because basically it's really just electrolytes in water, and they can cross the capillary membrane. So you can get peripheral edema if you're giving a lot of isotonic solutions. And you will dilute lab values, especially a lab value such as potassium. These solutions, unless you purposely add potassium to them, do not have large concentrations of potassium. So you will dilute and develop hypokalemia. So when wouldn't we use an isotonic solution? If the person's already volume overloaded, we likely wouldn't use any solution to add more volume to the system. Okay, hypertonic solutions. So these have more solutes dissolved within the solution than the intracellular space. An example of this, and it's not listed here, and the most common example would be 3% normal saline. So very salty normal saline. And this will cause fluid to shift out of the cells and into the vascular space. So we're pulling fluid out of cells. So when would that be useful? Well, theoretically, if you're pulling fluid into the vascular system, you could use it for hypovolemia, hypotension, and to re-expand the vascular space in hypotension. You could use it for someone who's had a severe head injury and you want to pull fluid out of the cerebral cells so that you can shrink the brain a bit and reduce overall pressure. We can use it to increase urine output because you're pulling more fluids into the vascular space, which will then go to the kidney and create more urine production. So just remember, hypertonic solutions are typically used though for pulling fluid out of brain cells to reduce pressure in the brain after a head injury. What do we watch out for? Well, they're typically, so hypervolemia because you're pulling fluid into the vascular space. Increased salt content because these are salty solutions. Unfortunately, the most common one isn't listed, 3% normal saline, so you can make them hypernatremic. Cellular dehydration, you're pulling fluid out of the cells. And because some of them consist of dextrose solutions, you can get hyperglycemia. So when wouldn't we give these? Well, definitely in cardiac patients, you can put them into congestive heart failure or pulmonary edema. In someone who has severe dehydration throughout the body, you're definitely going to pull fluid away from the cells and away from the interstitium, which is already dehydrated, and you'll dehydrate them further. And patients with renal issues or renal failure that can't produce a lot of urine, you will create a volume overload situation with them as well, because you're pulling all this fluid in, but you're unable to produce urine to release some of the fluid. So I won't spend too much time on this slide. This is a bit of repetition. Repetition's good though at the beginning. So isotonic fluids, perfect example, 0.9% normal saline or lactated ringers. Notice that lactated ringers does have salt or sodium and chloride. It has tiny bits of potassium and calcium as well. We tend to use lactated ringers in burn patients. Lactated ringers is much more similar to your serum than normal saline. So sometimes we say there's nothing normal about normal saline. Believe it or not, the pH of normal saline that we use all the time, every day, is 5.5. So it has a low pH. It can cause a bit of acidosis as we use it for days and days. So, but we do use both of these, okay, for the isotonic group. Hypotonic, so half normal saline, that should make sense. If you're using half the solutes of 0.9%, then you've made it a hypotonic solution. And it draws fluid from the blood vessels into the cells and causes cellular edema. D5W, most common reason to use D5W is to mix up medications and administer them. So it's not a common maintenance solution at all. Sometimes in children we'll use D5W as a maintenance solution, and I'll explain that a bit later. Hypertonic solutions. A common one, 3% normal saline. This will draw fluid out of cells and into the bloodstream. So it will shrink cells, which is very useful in cerebral edema from a stroke, in cerebral edema from a head injury. We try to draw fluids out of the intracellular compartment. And here's another slide on just some common IV solutions. So I would know the common ones. I'll list the common ones. 0.9% normal saline, used all the time. For, someone comes in vomiting and diarrhea and we want to rehydrate them, 0.9% normal saline. Somebody is in hospital getting maintenance fluids for 2 to 3 days to keep them hydrated, 0.9% normal saline. 0.5% normal saline, 0.45% normal saline, which is one half normal saline, is sometimes used. Say someone has a very high sodium level of 160 and you want to gradually bring it down into the normal range, we could use half normal saline, since it'll have half the sodium concentration and slowly bring down the sodium. 5% dextrose in water. By far the most common reason to use this is to mix up medications. Mix the medications in the solution and administer them intravenously. So that's the most. It's used as a diluent for medications mainly. 10% dextrose in water. We can use that for someone who comes in hypoglycemic sometimes. We can use that for someone who's receiving TPN, but the TPN has run out and there's none available in the short term. And what can happen there is that they had TPN, which is causing insulin to be secreted because there's sugar in TPN, and suddenly it runs out. Well, what can happen? The insulin can continue to push glucose into the cells, and they can become hypoglycemic. So a 10% dextrose drip could be administered to maintain their serum glucose levels. I'll skip right down to Ringer's lactate, which is an isotonic solution that we use very commonly as a maintenance solution, or in patients with burns. We use Ringer's lactate, or the other term for it is lactated Ringer's. So the next slide is types of dehydration disorders and their treatment. So it really depends on whether you're losing equal amounts of electrolytes, such in particular sodium, and equal amounts of water at the same time. So if you're losing equal amounts of water and sodium, then you'll be down overall in terms of your fluid status, but it'll be an isotonic loss, meaning you've lost sodium in equal amounts and you've lost water, so free water in equal amounts. So your extracellular fluid remains isotonic. There's been no net fluid shift because what you've lost is salt and water. Okay, so examples of this are often varying degrees of vomiting and diarrhea. Sometimes in certain renal diseases, or diuretics. Diuretics make you lose sodium, and you also lose water at the same time with diuretics working on the kidney. So how do we replace isotonic fluid loss? Well, we would just administer an isotonic solution, such as normal saline at 0.9%. Okay. We could also use Ringer's lactate because that is an isotonic solution as well. What about hypotonic contraction? So sodium without corresponding loss of water. So you're losing much more sodium than you are your water losses. So if you're losing more sodium, your extracellular fluid is going to become hypotonic because you're losing more salt than water. And that's going to cause a fluid shift from the extracellular fluid, which is low in sodium, so more free water, to shift into the cells, into the intracellular compartment. So what can cause this? Well, if you're using a diuretic that's preferentially taking more sodium away than it is the fluid of your body, then you're going to become hypotonic. It's drawing the salt out preferentially. Okay. And how can we correct that? Say someone they're dehydrated, but they've lost more salt than fluids, and their sodium is 120, or lower, say it's 110. Well, initially, to get the sodium up a bit more quickly, we can use hypertonic solutions that are much saltier than your typical normal saline at 0.9%. So we can use saline or hypertonic saline at 3%. Okay, we would not leave someone on this for a long time. It's just to get their sodium up to a safe level if it was extremely low. Okay, what about hypertonic contraction? So you're losing more water than you are sodium. Okay, and so if you're losing more water, your extracellular fluid is going to become saltier. Your sodium is going to climb, which means that fluid from inside your cells is going to try and dilute the salty extracellular fluid, and you're going to have cellular dehydration. Okay, so what causes you to lose water much faster than salt? And a good example of this would be excessive sweating. Okay, so you're losing tremendous amounts of fluid when you're sweating. Another one is an osmotic diuresis. So remember those osmotic diuretics such as mannitol, which is just going to make you lose incredible amounts of water and not as much salt? Well, your extracellular compartment, which is your interstitial fluid and your vascular compartment, is going to become hypertonic. It's going to become, you're going to be hypernatremic, high sodium. Okay. So another example where you lose a lot of water compared to salt are severe burns on your body, where you're leaking out tremendous amounts of water and not as much salt. So you become also hypertonic or hypernatremic. So in general, think of what's happening to the sodium compared to the water, because it's really sodium versus water when we're talking about these three different types of dehydration. Okay, and if you have high sodium, and we're talking about the last one here, hypertonic contraction. If you have high sodium, then what we can do initially is give someone a hypotonic solution. So say half normal saline, which would be 0.45% normal saline, because when they came into the hospital, their sodium, say, was 160, which is much too high, and we want to bring it down. So we're going to use a hypotonic solution to dilute the high sodium that's in the serum. Okay, I hope that makes a bit of sense. We'll come back to it. So let's talk about some colloid IV solutions. So we spoke about crystalloid solutions, those that have like electrolytes plus or minus sugar in them with the solution, which is a watery solution. A colloid is more of a suspension of large molecules that can be infused. So large molecules such as albumin or dextran. So dextran is just a large sugar molecule that's synthesized, that's made in a lab. So it's a type of starch. Head of starch. There's another starch. So these are volume expanders. Okay, so they don't leave the vascular space. They stay in the vascular space. So they can increase oncotic pressure and pull fluid into the vascular space. Okay, so they were initially produced with the feeling that, well, if they're large molecules and they last for a couple of days and they pull fluid into the vascular space, they'd be very useful for, say, conditions such as hypotension or maybe hemorrhagic shock or sepsis to raise the blood pressure. Unfortunately, most of the studies over the years didn't show that these were any more effective. So they're not used very commonly. You still need to know them because you'll come across them, but just know that they're not used as commonly as crystalloid solutions. Okay. These can also be used in surgeries. So pre-surgery, these can be given as a volume expander to make sure that the patient maintains vascular volume. Okay, so know the difference a bit between a colloid and a crystalloid. Colloids are just a solution of large molecules, albumin or dextran. So let's look at just a comparative study or summary of the crystalloids versus colloids. So on the left, crystalloids, by far the most common IV solutions. Most people you see with an IV and fluids infusing, they're going to be crystalloids. So how long do they stay in the bloodstream for? Well, not very long, like 30 minutes, 60 minutes. It's just fluid and electrolytes. So it's going to it's going to leave the blood, the vascular space and go into the interstitial space, and some will go into cells. So they're not fantastic volume expanders. It's just that colloids haven't been shown to be any more effective, and we'll see that they're much more expensive. So, so if you were to infuse a liter of normal saline, say, or Ringer's lactate, only a third of it will stay in the vascular space. Most of it leaves the vascular space. So 3 times the volume needed for replacement. So if you wanted a liter to stay in the vascular space, you'd have to give 3 liters of a crystalloid. Okay, so they're not great volume expanders, but we still use them. We still use isotonic solutions such as normal saline or Ringer's lactate to volume expand and to rehydrate people. They can lead to peripheral edema, pulmonary edema from volume overload. The molecules, the electrolytes, easily pass the capillary walls, so they're freely able to pass into the interstitial fluid and sometimes into cells. They're very inexpensive, no allergies. I think there's one which is extremely rare, a corn allergy with D5W, but that's the only one I've ever heard of. Colloid solutions, used far less frequently. They can last for hours to days in the bloodstream. So something like albumin or dextran. They are considered volume expanders, so they pull fluid into the vascular space. They can cause congestive heart failure by being a volume expander and overloading a cardiac patient. The molecules in a colloid solution don't cross the capillary membrane at all. They stay in the vascular space. Much more expensive than crystalloid solutions. They run the risk of an anaphylactic reaction because they're synthetic. They're synthetically made, so you can have a reaction to them. Okay, so really think of IV solutions as mainly crystalloids, but we will talk about some colloid solutions as well. Okay, so let's talk about an IV solution. Normal saline, salty water, just has sodium and chloride in it. And it comes in varying concentrations. The one that is isotonic with the body is 0.9% normal saline. So what's half normal saline? 0.45%. What's hypertonic normal saline? 3%. I've never seen 0.22% used. I don't think it's very common. So what are the indications for isotonic, which is 0.9, normal saline? Well, you could use it as fluid resuscitation, so electrolyte and fluid resuscitation, since it's isotonic. It'll increase the vascular volume. It'll also cross the vascular membrane and rehydrate the interstitial compartment, and also some of it will go to the cells as well. Okay, it will also treat hyponatremia. So say you have someone with a sodium of 125 and they're feeling a bit weak, and they need replacement with sodium. We can start IV normal saline, which has a sodium of 154, and it'll gradually raise the sodium to a normal level. And if actually continued for days and days, it would go beyond the normal level, because normal is 135 to 145 in the blood, and normal saline is 154. Ophthalmic solutions for dry eyes. So all those basically salt solutions that you can buy for dry eyes or nasal congestion or a nasal rinse, they're just salty water, expensive salty water. Okay, 3% normal saline. So that's getting pretty aggressive. We use that for people that are quite ill because that is really hypertonic. So if we're using 3% normal saline, we're going to pull fluid out of the cells. We're going to shrink the cells, which we sometimes want to do in elevated intracerebral pressures to reduce the pressures in the brain, or sometimes in someone who has something like glaucoma and they have elevated intraocular pressures, and we want to pull some fluid out of the eyeball. Okay, so, but the main one here is the isotonic one, 0.9%. So we use normal saline as a fluid replacement and a sodium supplementation or replacement. So what are the adverse effects? Well, if you were to stay on normal saline for days and days and days, because it has a sodium level of 154, you can become hypernatremic. Okay, and with hypernatremia, you'll get the following: confusion, lethargy, and reduced level of consciousness changes. Okay, so it's because of the higher sodium content in the normal saline than your bloodstream. Contraindications. Well, someone who already has hypernatremia, we wouldn't use it. Someone who has heart failure that we might aggravate. Well, there's a lot of salt in normal saline. That's going to potentially, and of course the volume that's associated with it, so that we can volume overload people. And we can also volume overload them if they have very weak kidneys and they aren't making a lot of urine. So the vascular space is not able to, it'll become overloaded with fluid because the kidneys are so weak. Nursing responsibilities, input and output documentation, daily weights, vital signs, checking labs, blood sugar. There's no sugar in normal saline. So if that's the only thing they're receiving and they're not eating, some people can become hypoglycemic. So the next one is 5% dextrose in water. So sugary water, 5%. You can make it more concentrated sugar, such as 10% dextrose, 20% dextrose, or even 50% dextrose, which is extremely sugary. So why would we have these solutions of sugar and water? Well, 5% dextrose is sometimes used as a maintenance solution in children. Children have very low glycogen stores. They run out of glycogen very quickly. So we have to make sure that they receive some kind of a dextrose solution so that they don't become hypoglycemic. And 5% dextrose is just fine as a maintenance for children. As mentioned, the most common reason for using a mini bag of 5% dextrose would be just a diluent for medications. So you inject the medication, say it's an antibiotic, into the D5W, and then you hang it and drip it in. Water replacement, that would be a pretty uncommon reason just to replace water. Usually you're trying to replace water and electrolytes. Remember that D5W is considered isotonic, but it quickly becomes hypotonic in the bloodstream. And for someone who becomes hypoglycemic, so say they took too much insulin at home and they've come in semi-comatose or unconscious, and we do a glucometer, and we see that their sugar's 30 or 40, we can give them a D50 amp. So we will push in D50 amps to get their sugar up quickly. As mentioned before, someone who was on TPN and the bag ran out, and another bag needs to be obtained from from pharmacy. In the meantime, they can become hypoglycemic since they still have circulating insulin. So D10W can be given as an IV fluid to maintain their sugar levels until the next bag of TPN arrives. So it can be used for rehydration, not usually. It's more just to dilute medications. Can you get fluid overload with this? You can get fluid overload with any solution. You can overload someone's vascular volume. Hyperglycemia, sure, it's a sugar solution. Hemodilution, yeah, when you're giving IV fluids, you're typically hemodiluting, right? So you're diluting electrolytes, especially if the solution doesn't have electrolytes, and you're diluting the hemoglobin as well. So it's not uncommon to notice the next day that after someone's been on IV fluids, that their hemoglobin is lower because you've diluted the total blood volume. Putting someone into heart failure with IV solutions is definitely possible. Any of them. And peripheral edema, well, this is electrolytes, whether we're talking about normal saline or D5W, can easily cross the capillary membranes and cause peripheral edema. So contraindications, we would have to be careful with someone who has heart failure, someone who has intracranial pressure that's elevated or intraocular pressure that's elevated. We definitely wouldn't want to use this solution. This will cause the fluid to shift into cells, causing more edema of the cells and more pressure. Someone who's already hyperglycemic, this wouldn't be good. It will contribute to more hyperglycemia. And there's a rare corn allergy associated with dextrose, with D5W. Most of the crystalloids don't have any allergies at all. It's not a concern. This one has a rare corn allergy. Nursing responsibilities for any fluid administration, monitoring input and output, daily weights, monitoring vital signs, monitoring electrolytes and blood sugar. And as mentioned before, D10W can be used for hypoglycemia when TPN is delayed. The solution is initially isotonic, but quickly becomes hypotonic. So it's really not a good maintenance solution at all.
Okay, so we're still on colloids here. So here's a large molecule, dextran 40. It'll be similar to another one called hetastarch. Starch is just a large sugar molecule. It can't leave the bloodstream. Okay, so dextran, large sugar molecule. Indications: we could use it for hypovolemic shock since it'll stay in the vascular system. Related to hemorrhage, usually if someone's hemorrhaging, we'll use the real stuff. We'll infuse blood. If you're losing blood, we're going to replace it with blood. Sometimes it takes a bit of time to obtain packed red blood cells, so we could use either a crystalloid such as Ringer's lactate or normal saline, or we could consider using a colloid such as dextran. I mentioned the microsurgery before, how it keeps the plasma volume expanded, so good for microsurgery. In severe burns, these can be considered. They're not used very often in severe burns any longer. But again, it keeps the vascular system expanded. So just remember that concept. DVT prevention. Well, if you're keeping your intravascular space expanded, the blood is flowing. There's less chance of getting a DVT. Again, the evidence showed that this wasn't very effective. Action: doubles plasma volume in last 12 hours, reduces platelet adhesiveness, reduces blood viscosity, improves blood flow through capillaries. So that is true. So we call them volume expanders. Okay. Unfortunately, it didn't show that it had any benefit over crystalloid solutions. So we've really reduced using them. But it does do all those things. So reducing platelet adhesiveness. So if you were on one of these, it could prevent a DVT. Reduces blood viscosity. That could prevent a DVT. And it expands the volume. That could help with blood pressure and hemorrhagic shock. Okay. Adverse effects, pulmonary and cerebral edema. Sure, you've increased your circulating vascular volume. Okay. There is an increased chance of bleeding on these because you've altered the platelet stickiness with these volume expanders. So that's one of the reasons why they fell out of favor with trauma. So if you're already bleeding from somewhere, from a traumatic injury, we don't want to reduce platelet adhesiveness and stickiness. Okay, so they fell out of favor. Fluid overload, well, that's congestive heart failure. Because these don't leave the vascular space, they can definitely cause fluid overload. And because they're synthetic, it can cause anaphylaxis, unlike crystalloid solutions that don't. Contraindications, well, clotting deficits, because we just mentioned that they reduce platelet adhesiveness. Congestive heart failure, for sure. And renal failure. If you have renal failure and you're not making urine, and you give these colloidal solutions, and you've expanded your volume in your circulating plasma volume, you'll become fluid overloaded and again go into congestive heart failure. So same nursing responsibilities, ins and outs, daily weights, vital signs, observing for signs and symptoms of fluid overload. Okay, so just think of them as molecules and fluid that does not leave the vascular space, and just not as commonly used anymore.
Okay, so let's look at blood products. So whole blood is removed at a blood donor clinic, but we rarely infuse whole blood into a patient. We want to take the components of the blood and separate them and use them for different indications. Rarely does someone need whole blood. So it's really rarely used. You get the components in a hospital. So for example, packed red blood cells. So one unit of packed red blood cells typically will raise your hemoglobin by 1 gram per deciliter. Okay, and so someone, for example, who is anemic and they're symptomatic with their anemia. So they have a hemoglobin of, say, 5 or 6, and they have angina, profound weakness, they're not able to walk, they're very short of breath. We will we will give them packed red blood cell transfusions because that's all they need to raise their hemoglobin. Someone who's hemorrhaging, well, they're hemorrhaging blood. They likely will need packed red blood cells. They'll likely need some fresh frozen plasma, and they'll likely need platelets. That's not listed here for some reason. So if they're losing all the components of blood, we're going to replace the red blood cells, the plasma, and the platelets in a massive hemorrhage, that is. Fresh frozen plasma by itself is highly concentrated in clotting factors, not with platelets. So we would use this as a replacement for clotting factors. Say, for example, in someone who's on warfarin. So warfarin inhibits the production of vitamin K dependent clotting factors. Okay, so any clotting factor that needs vitamin K is not produced in the setting of warfarin.
So if someone comes in hemorrhaging on warfarin, we can give them vitamin K so their liver can start making those clotting factors, but that can take a day or two. We need clotting factors right now, so we can provide them with fresh frozen plasma to give them those clotting factors immediately. Cryoprecipitate was, again, it was a concentrated preparation from fresh frozen plasma. It was also used for bleeding disorders. Not so much anymore. Hemophiliacs actually have synthesized in the lab clotting factors. So we don't need to use cryoprecipitate for that as much anymore. Immunoglobulins, antibodies. So we can use antibodies in someone who has some kind of immunodeficiency, some disease where they're antibody deficient. And there's people that get recurrent infections because they have disorders of antibody production. We can also use immune globulins for passive immunity to a lot of infections, such as hepatitis A exposure, hepatitis B exposure, where they don't have immunity to these diseases, so we want to protect them, such as in the case of rabies. We want to protect them with passive immunity with an immune globulin. RhoGAM is an antibody. So RhoGAM is used in pregnant women that are Rh negative, and the fetus, which is likely Rh positive, can share blood with the mother. So there's Rh positive blood going into the maternal bloodstream, and it's going to sensitize the mother to make antibodies to the Rh red blood cells of the fetus of the next pregnancy, which can harm the fetus. It can cause hemolysis in the fetal bloodstream. So we use RhoGAM, which is an antibody to Rh factor, to bind any fetal blood that's coming into the maternal circulation, so that the mother doesn't recognize the Rh factor and produce antibodies to it. Okay, so let's discuss potassium as a, well, it's an electrolyte, but we administer it well, technically as a medication too. So it's for people that are hypokalemic for a variety of reasons. So whether they've been receiving tremendous amounts of diuretics, or they've had tremendous amounts of vomiting and diarrhea, and they're hypokalemic. There's many reasons for hypokalemia, and we can administer potassium in an IV solution, or we can give it orally. So the main indication for potassium replacement is hypokalemia. And potassium comes in IV solutions. It gets added to IV solutions. Now, years ago, the nursing staff could draw up potassium in a syringe and inject it into the IV bag and come up with a concentration. That has essentially disappeared now, and companies now make normal saline with potassium added to it. So on the bag, it'll say 0.9% normal saline with 20 milliequivalents of potassium, or 40 milliequivalents of potassium. And that's for safety reasons, so that it takes the human factor out of mixing up the bags with potassium, because it can potentially be a deadly electrolyte to administer. So what are the adverse effects of potassium, whether we give it IV or orally? The main adverse effect is we've given too much, hyperkalemia. That's unusual unless they have severe renal failure and they just can't clear the potassium that we're giving.
And often we will notice someone who has severe renal failure based on their blood work, and we'll be super careful with administering potassium. What does potassium do if you have high potassium? Well, on the ECG, we'll see, and we'll get into this throughout the semester, but you'll see tall peaked T waves, a widening of the QRS, and that, as it progresses, will progress to, unfortunately, cardiac arrest. So whenever you see hyperkalemia, you should really be thinking cardiac arrhythmias and cardiac arrest as the adverse effect. Oral potassium tastes awful, so it's often mixed by the nursing staff with orange juice, some kind of solution to offset that terrible taste. So potassium can give you nausea, vomiting, abdominal pain if given orally. What are the contraindications for potassium? Well, if you already have high potassium, we would avoid it. Severe dehydration, where your kidneys aren't being perfused well yet, that would be risky because you're giving potassium, but you don't have a good way of excreting it with the kidneys if you're severely dehydrated. Burns or trauma. Often in burns or trauma, because you've damaged cells, they're releasing potassium into the bloodstream. So those conditions can cause hyperkalemia in themselves. So we'd be careful not to administer potassium unless we checked it first. And reduced renal function and renal failure, we're careful to administer potassium because it's not easily excreted from the kidneys. The nursing responsibilities are very similar. We never push potassium. You never push IV potassium. We often dilute it in a liquid for oral potassium administration, and we don't break the tablets when given orally. Okay, so let's do albumin next. So IV albumin. Remember that you saw IV albumin under colloids. So albumin is a very large molecule. Naturally it's made in your liver, and it maintains oncotic pressure in your vascular system, right? So when your liver fails, such as in cirrhosis, and your albumin is vastly reduced in production, you get peripheral edema, and you get massive ascites, which is fluid in the intra-abdominal space. So why would we use IV albumin? Well, first of all, it's a blood product, so we typically need a consent, just like other blood products, whether they're packed red blood cells, platelet transfusions, fresh frozen plasma, unless it's an emergency. We don't need the consent during a life-threatening emergency. And albumin is given to maintain plasma oncotic pressure. So say someone with hypoproteinemia from liver failure or from cirrhosis, to maintain the oncotic pressure so that they don't get massive ascites and massive peripheral edema. So someone with hypoproteinemia would be someone who might receive albumin infusions. We could consider giving it in someone in hypovolemic shock because it's a volume expander. It doesn't leave the blood vessel. So it actually draws fluid into the vascular system. Someone with burns is losing large amounts of fluid from their system. And albumin can keep that fluid in the vascular space as well. So think of it as a volume expander, as a replacement for albumin for someone who's got cirrhosis to avoid massive ascites and peripheral edema. And someone who has been severely burned, and we want to give them albumin to maintain, to control the fluid from leaking out of all their vascular beds, which happens in burn patients. So those are the main indications. So the actions we've already mentioned. The adverse effects, fluid overload for sure. You're pulling fluid into the vascular space with albumin. You're increasing oncotic pressure. Blood reactions and allergic reactions to the albumin can occur. Contraindications, so definitely congestive heart failure, previous allergic reactions to an albumin infusion. Severe anemia is if someone's severely anemic, and you infuse albumin and you draw fluid from the interstitial space into the vascular space, you're actually diluting blood. So they're going to get a dilutional anemia, a worsening anemia. Okay, nursing responsibilities. Remember, there's fluid shifts. There's all kinds of shifting going on. So you want to check ins and outs, daily weights, vital signs, laboratory such as electrolytes and albumin level, and also to check for any transfusion reactions because it is a blood product. So I think this slide on midazolam, vecuronium, and potassium is was used for lethal injection for the death penalty. Let's just talk about the drugs. So midazolam. So because in the end, you kind of need to recognize drugs in questions and in clinical settings. So the more information that you hear and the more you gets repeated, the higher likelihood you're going to recognize it later. So midazolam, it's a benzodiazepine. So there's many benzodiazepines, lorazepam, midazolam. There's so many of them, and they're sedatives, right? So they act on the brain, and they stimulate the GABA system, and the GABA system is an inhibitory nerve complex in the brain. And when you stimulate an inhibitory nerve complex in the brain, you get sedation. So they're very powerful sedatives, especially IV. Vecuronium. Well, there's vecuronium, rocuronium, pancuronium. Just recognize the last part of the drug name, and these are non-depolarizing skeletal muscle paralyzers. So they're neuromuscular blockers. Okay, so they completely paralyze someone for different periods of time. So, for example, rocuronium will paralyze someone for 30 to 40 minutes. Other ones will paralyze someone for longer. Succinylcholine, which is a depolarizing neuromuscular blocker, or a skeletal muscle paralytic, typically paralyzes someone for 6 to 8 minutes. So we use the length of time depending on what we need to do, what kind of surgery is being done, to choose which one to use to paralyze a patient to keep them still. Potassium chloride, that's potassium replacement. In this case, in a high dose, it's lethal to the patient or to the person because it causes cardiac arrest. So they get heavily sedated, vecuronium for paralysis, complete paralysis, including the respiratory muscles, and potassium to cause cardiac arrest. Okay, so the next this is an electrolyte, so magnesium sulfate. So let's go over this one a bit. So indications. So hypomagnesemia. So low magnesium can happen, and if there's one thing you might want to remember for this electrolyte is its best friend is potassium. So when potassium is depleted in the body, say from diuretics, magnesium goes with it. So if you have low potassium, you often have low magnesium. So we often will give magnesium infusion if someone is low on potassium, and then we get the magnesium back, which is almost always low as well. Magnesium is in many laxatives. Milk magnesia, perfect example. It's a very good laxative. We use it in severe preeclampsia. So preeclampsia is the condition of, well, pregnancy, hypertension, proteinuria. So in severe preeclampsia, where we think someone might have seizures, which now we call eclampsia. So the only difference between those two is that eclampsia is all those other things plus seizures. They both have peripheral edema. They both have proteinuria. They both have hypertension. Eclampsia has the seizures too. So IV magnesium sulfate is the primary treatment for severe preeclampsia or eclampsia. Preterm labor, magnesium sulfate IV is sometimes tried to slow down or stop preterm labor. And we also use it in severe asthma where we've tried everything: albuterol, ipratropium, IV corticosteroids, and we're just giving repeated masks of albuterol. And then we go to epinephrine and all kinds of other drugs. And finally, we decide, let's just try magnesium because it's a bronchodilator. So we will try it to avoid intubating an asthmatic. And magnesium sulfate is the treatment for that term you've heard before, torsade de pointes, which is a type of VTAC, ventricular tachycardia, from a prolonged QT. So if we know someone has torsade de pointes from a prolonged QT, from multiple drugs that have prolonged the QT, the treatment is IV magnesium. So adverse effects, well, don't forget it's a laxative. So let's start talking about GI upset if you didn't need it as laxative, or diarrhea. It can cause fatigue in some people. Now, as it gets to higher doses that we use in IV to try and stop preeclampsia or eclampsia, it can cause hypotension, decreased deep tendon reflexes. And actually, if a woman is on magnesium for preeclampsia or eclampsia, the nurse often checks the deep tendon reflexes and the level of consciousness of the patient, because that can start to be affected when they become magnesium toxic. So decreased deep tendon reflexes and decreased level of consciousness for IV magnesium for a woman who's severely preeclamptic or eclamptic. Contraindications, there aren't that many. I guess undiagnosed abdominal pain or obstruction, you wouldn't want to give a laxative, which magnesium is. Chronic kidney disease. So magnesium and calcium are always opposite each other when you have chronic kidney disease. So if you have an elevated calcium, you typically have a low magnesium. Elevated magnesium, low calcium. So with chronic kidney disease, you don't excrete magnesium very well. And you can become magnesium toxic. So that's why we wouldn't use milk magnesia as a laxative for someone with chronic kidney disease. We'd use a calcium-based laxative or a calcium-based antacid as opposed to a magnesium-based. Okay. Nursing responsibilities, watching for signs of
IV of toxicity to the IV form. So absence of patellar deep tendon reflexes, decreased level of consciousness would be really important. The respiratory rate can diminish with IV magnesium toxicity as well, and you can get cardiac arrhythmias. So we would, if we saw these things happening, reduction in reflexes, decreased level of consciousness, decreased respiratory rate, we'd stop the IV drip and we'd give a calcium, IV calcium, either as calcium gluconate or calcium chloride, that protects the heart from the magnesium.
So we're going to talk about gestational hypertension. So hypertension with pregnancy and a condition called preeclampsia. And preeclampsia plus seizures equals eclampsia, which is just one level even worse. Now you have seizures and you're pregnant in the setting of initial preeclampsia. So let's so aspirin. I'm gonna skip the first sentence first. So aspirin is given to patients that are pregnant that are at high risk of preeclampsia. So say for example they had preeclampsia in the past, or we notice that they're developing hypertension and some proteinuria in the first trimester. Low-dose aspirin can be effective to minimize the effects of preeclampsia early on. Okay, so that's a good thing to remember. So gestational hypertension is not preeclampsia. Gestational hypertension just means I happen to have high blood pressure during pregnancy. And those are some of the medications that we use to treat women that are pregnant and that have developed gestational hypertension. We'll talk about some of them as the weeks go by. Methyldopa, that's that lovely alpha-2 agonist, just like clonidine, but we use methyldopa sometimes in pregnancy. Nifedipine is a calcium channel blocker. I don't think you need to memorize this right now. We'll go over it again. Hydralazine is a arterial vasodilator, and labetalol is a beta blocker. So we'll go over those, but just know that there are medications that we use for gestational hypertension to control the level of the blood pressure. Now, when we're talking about preeclampsia, what that means is that someone who's pregnant has developed, and it's usually as the pregnancy heads into the third trimester, but someone has developed hypertension in the setting of also proteinuria, so you're leaking protein into your urine. You have peripheral edema as well. And you're coming in sometimes complaining of abdominal pain because when you're hypertensive, you can have a bit of distension of the liver capsule, so you can have some upper abdominal pain from that. Or you're coming in because you have headaches, and we check you and realize, ooh, blood pressure's up, leaking protein into the urine, and peripheral edema. So it's not uncommon for someone who's pregnant in the third trimester to have a bit of edema in their legs. That's common. But it wouldn't be normal to have hypertension, proteinuria, edema in their legs, potentially abdominal pain or headaches associated with them. So these women typically have to go on to bed rest to try and control the blood pressure, and some of these antihypertensive medications to lower the blood pressure associated with preeclampsia. And remember, the treatment for preeclampsia or eclampsia is delivery of the baby. That is the main treatment to stop these from happening. All we can do is try and treat them initially. So if you have mild preeclampsia, we'll follow you every week in terms of your hypertension and your proteinuria. You may be on a blood pressure medication to maintain a proper blood pressure. But just know that the final treatment that will resolve these is delivery of the fetus. Okay? So magnesium sulfate, in someone who has severe preeclampsia, and we think they might go on to have seizures, so not only do they have bed rest and medications to control their hypertension, but we may administer magnesium to prevent someone with severe preeclampsia from going into seizures. And we also use magnesium intravenously for someone who has had seizures. So that's someone who's eclamptic. So think of magnesium as the medication to either stop the seizure from occurring with severe preeclampsia, or someone who's had a seizure and they are already eclamptic. And the consideration at that point becomes, when can we deliver the baby? When is it safe to deliver the baby? Because this is becoming unsafe for the mother. And what do we look for when someone's on magnesium? So often the nurse is looking for signs of too much magnesium in the system. And that's usually hypotension, so we'll follow the vital signs. The reduced deep tendon reflexes, so regular checks of the deep tendon reflexes, and these are done for sure on maternal floors. Reduced level of consciousness, magnesium sedates you. Decreased respiratory rate, magnesium can reduce your respiratory rate. Okay. We'll also monitor the fetal heart rate, fetal activity. So just understand that magnesium is related to either prevent or treat seizures. Those medications that's listed under gestational hypertension can be used in preeclampsia or eclampsia before delivery happens to treat the blood pressure, or they can be used just for someone who has hypertension in pregnancy, but they don't have preeclampsia yet. Okay, so I hope that helps with the understanding. So this last slide is an interesting condition. It's a severe form of preeclampsia that we call HELP syndrome. And because preeclampsia, we think, is a condition of the arterioles, of the vascular system, and that's partly why you get hypertension associated with it, and you get leaky glomerulus, where you're leaking protein into the urine. So HELP syndrome stands for hemolysis, so breakdown of red blood cells within the vascular system, elevated liver enzymes, and low platelets. Okay, so elevated liver enzymes is occurring because there's some kind of vasculitis or some kind of inflammation happening within the blood vessels in this syndrome. That's also leading to the hemolysis. That's also leading to the low platelets. The platelets are being broken down within the blood vessels. So it can be a pretty dangerous condition. You can imagine hemolysis, so you're becoming anemic. This is in the setting of preeclampsia as well. Elevated liver enzymes and low platelets. So now you're at risk of bleeding. So what do these patients need? What do these mothers need? Sometimes they'll need a blood transfusion. They're often on bed rest because of the preeclampsia already. They're on blood pressure medication because of the preeclampsia. There's continuous monitoring of the mother's vital signs and the fetus to check for any fetal distress. You'll see in the corner there, blood pressure medications. Corticosteroids are injected into the mother to accelerate development of the fetal lungs. Typically, it's betamethasone. So corticosteroids are used in pregnancy, in preterm labor, for example, to accelerate development of surfactant in the fetal lungs in case delivery occurs soon and the baby's premature. Because one of the main issues of a premature infant is that the lungs are not mature enough to oxygenate and to ventilate. So corticosteroids can accelerate that a bit. And often magnesium sulfate is used to prevent these people, these patients that have HELP syndrome, because this is a severe form of preeclampsia. So magnesium sulfate is used to prevent seizures. And again, the treatment for this is to remove the fetus, to deliver the fetus, and HELP syndrome, preeclampsia will then go away. So that's the main treatment. Everything else is just to manage the symptoms and to control the situation.